Hello, I am Leif McGuire, and I'm the owner of McGuire Physical Therapy. And we have developed a system that allows us to give physicians, nurse case managers, the people that are actually managing patients' cases, we're trying to give them information that they really want that we haven't been giving them. They really want to know functional abilities of a patient. And as physical therapists, a lot of times we're giving them range of motion, we're giving them things like that, but they're really not getting the information they want. And until now, really to get that information, they would have to order a functional capacity exam, which you know is quite costly. They take 4 to 6 hours. Usually those are done at the time of a case management that it's too late. So we're trying to provide that similar information but in real time. And we've gotten kind of creative about how we've done that. We're actually pulling that information out of the person's gym exercise program that's being supervised, it's being recorded and timed, and that information is being pulled out in such a way that after a person has had 6 physical therapy treatments, they have basically a modified functional capacity exam. And that exam starts the first day. When you look at it, we're going to just kind of start breaking this into segments. The first segment would deal with sitting, for instance. So if a person's been sitting in the waiting room, you have a pretty good idea of their tolerance to sitting just based on that. And as you're doing some motivational interviewing, once they're brought back into the room, you'll want to let them know, first of all, that if their symptoms start getting aggravated from sitting, for instance, then go ahead and stand. Stand for as long as they need to recover from that mild flare-up, and then sit down again. That's important information, because from that information we're going to determine their sitting tolerance. For instance, if they could sit for 20 minutes and then they start getting symptom aggravation and they have to change posture after that for say 10 minutes, maybe they have to lay down or they have to stand until they recovered enough to sit again, then that tells us that they can sit for about twice as long as it takes to recover. That would be a 50% ratio, and our form is going to calculate that in such a way that it gives us a patient's ability, which would equal to a frequent basis versus an occasional or a constant. And what's nice about this system is you don't have to do the math. You just fill in the numbers and the spreadsheet does that for you. So sitting would be done that way. Standing the same way. Now standing might take a little bit more interviewing. Again, asking the patient, how long can you typically stand before you have to sit down and recover from that activity? And then you just plug in the numbers. It's always best to get these numbers out of direct observation though. And so that's where when you're in the gym and you're actually having the person perform exercise, you always want to start with the instruction that you're going to be standing a lot today. If your symptoms start to get aggravated and you need to sit down, just let me know. You can sit down. When you have recovered from that, you'll stand back up. You're going to keep track of those times and plug them into the equation so that we can get a pretty accurate standing tolerance. The same thing would be with walking, and this is something that you could obtain even when you're warming a patient up on a treadmill. You can get a pretty good idea of this. Sometimes you will see this observation directly. Sometimes it will take some interviewing while the person is on the treadmill. If they can't tolerate treadmill for a warm-up, maybe they'll do a stationary bike or an upper body bike, but you kind of get the idea. We're just looking at tolerances. And the other thing that's important here is if you've had any exposure to functional capacity exams, you're going to realize right away that people don't give reliable efforts a lot of times because they know they're being tested. And this isn't like that. We're not testing people. As far as the patient knows, we're just performing exercises. And whenever a patient performs an exercise in our gym, we record things like duration, intensity, pain response. We're doing all of this stuff anyway. So as far as the patient is concerned, this is really just an exercise program we're pulling important information out of that, and we're making it easily accessible to those that need to be making decisions on that information. So if the physician needs to send that person back to work, they need to know what has the person demonstrated the ability to do. This is not necessarily going to pick out that person that's sandbagging or maybe malingering or giving an inconsistent effort. You know, that's for the stage of the recovery that's better left for a full-blown FCE. This is a modified version of this, and all we're doing is really looking at an exercise flow sheet, and out of that exercise flow sheet, we're making a pretty good educated guess on what their current real-time functional abilities are. And because of that, you might want to remember too, I don't see this happening the first or second visit. This is something that you might be able to pull some information, but I would recommend waiting until the third or fourth visit, and then running a person through these functional exercises. Again, that's how I would present it to the patient. We're going to run you through some functional exercises, and we're going to get an idea of what you can do today, and then we will be comparing that performance to what you might be able to do in a couple weeks from now. So maximum effort is important, but staying within your tolerance is important as well. So I cannot emphasize enough that you're going to do the best that you can. You can work up to pain, but I don't necessarily want you working into pain. And then as we're phrasing it like that, this information I think is going to be very usable. I think when you send this to a nurse case manager, to a physician, and not just in the case of a workers' comp patient, but physicians really have to deal with disability decisions every day on their patients. They really do not like filling these forms out because they don't really have the information to fill it out accurately. They don't even have a bit of information, and even if a person has went to physical therapy, they really don't have the type of information that they need. You know, they might know that the person is restricted into glenohumeral joint mobility, into inferior glides, and their scapulothoracic rhythm is off, and all of these things that are important to physical therapists. But guess what? What's important to us and what helps us do our job better is not what's important to the people that are paying us. And we need to change that, and we need to change it in such a way that we are adding value to the healthcare system, and we're doing it in such a way that the healthcare system really does not incur additional costs. This is something that is billed as therapeutic exercise because that's exactly what we're doing. We're just pulling information out of that therapeutic exercise that is much more useful information than Mr. So-and-so did 3 sets of 10 repetitions of chest presses with 30 pounds. That information is useful to us as we're progressing a patient. It's of no value to those that are paying us, and this approach is going to change that.